Good evening, everyone. I really welcome you all. Thank you for all the support and uh, uh, given to us. Today again, welcome Dr. Deepak Balasrubramaniam sir to give his second speech on eyelid and lip reconstruction. So with these words, I want to hand over the mic to Subramaniam sir. Please.
Yep. Is the PowerPoint visible?
Yes, sir. Your PowerPoint is visible and your audio is also good.
Yeah. Okay. So at the outset, I'd like to thank the organizers for, giving me another chance to speak. And as I promised last week, the talk was the plan was to give a talk on eyelid reconstruction and lip reconstruction, because those are two things that we generally don't get to see. So we have a brief presentation on eyelid reconstruction, and then we have a slightly more detailed presentation on lip reconstruction. Is the PowerPoint visible? Because I can
Yes.
see.
Yes, sir. It's visible, sir.
Okay. So see, earlier, there are a wide variety of tumors that can affect the eyelids. You can have starting from skin tumors, you can have meibomian gland tumors, you can have tumors of the conjunctiva or the mucosal surface, you can have tumors of the lacrimal apparatus, or you can have tumors that are of the skin from the surrounding cheek, which have invaded the eyelid. So earlier, before the advent of Mohs surgery and cryosurgery, a lot of the eyelid surgeries used to be quite debilitating. And it used to be full thickness resections of either the upper lid or the lower lid. So a lot of the eyelid reconstruction techniques have been described a long time ago, like 1950s and 60s, is when the principles of eyelid reconstruction came to be. And nothing much has changed, actually. We still follow the same surgical techniques and principles that were described 30, 40 years ago. But it's always good to conceptualize the reconstruction, because you need to know what are the goals of reconstruction and how best to achieve them. So if you look at the sagittal section of the globe and the eyelids, you can see that the eyelid is a complicated structure. You don't have it's not as simple as skin in the other areas, because you have the skin, then you have the very sparse subcutaneous tissue, then you have the muscle, which is the orbicularis, then you have the structural um, the structure that gives support to the lids, that is the tarsal plates, and then you have the levators of the lid, and then you have the sling which keeps the lower lid in place via the medial and lateral canthal ligaments. Now, for purposes of reconstruction, we have to divide the reconstruction into the structure of the eyelid into two. That is the anterior lamella and the posterior lamella. The anterior lamella is the skin, the subcutaneous, and the orbicularis muscle, and the posterior lamella is the tarsal plates and the conjunctiva. Now, no eyelid reconstruction is complete unless both the anterior and the posterior lamella are reconstructed. So the goals of this presentation is to understand the importance of reconstructing the anterior and posterior lamella, to focus on reconstruction of full thickness defects of the lid, to understand the local flaps that are available, and decide which flap to use depending on the size of the defect. Uh, After the initial description of these defects, there have been several modifications which exist in literature, but I've gone through the modifications that have been described. But in a sense, if you know the original procedure quite well, you can get away by doing a good eyelid reconstruction. So as I mentioned, the types of lid loss can be partial thickness, meaning in most common cases can be the skin and the orbicularis, preserving the structural integrity, that is a tarsal plate, or it can be full thickness, like squamous cell carcinomas, which have invaded through and through. And that is probably what we more commonly encounter in India compared to the BCCs that are seen in the West. Now, what are the goals of reconstruction? You must have a smooth inner mucosal surface, or rather, you should have a non keratinized surface that is a substitute for the conjunctiva. You have to have good outer skin lining. You must reconstruct the structural support of the eyelid by doing tarsal replacement. You should have a smooth, non-abraded eyelid margin, because if your eyelid margin is inverted or your eyelid margin is red and granulating, it can affect the cornea. You have to maintain normal vertical height and movement of the upper lid, meaning you have to reapproximate the levators, mainly the levator and the Muller's muscle, and you have to ensure that you have normal medial and lateral canthal positions. And in the end, you should maintain good globe contour. Now, usually for partial thickness losses, that is, you have either the anterior lamella or the posterior lamella that has been resected, then you can use static grafts, because you have a vascular bed where you can place these static grafts. So if you lose the skin of the eyelid, you can use a full thickness skin graft, and usually the post-auricular skin is a good donor site for the skin graft. So if you have isolated skin defects, a full thickness skin graft does work. If you have conjunctival defects, isolated conjunctival defects, free mucosal grafts will work. There are different sources, buccal mucosa, nasal mucosa, but we must remember that we cannot use skin as a lining for the conjunctiva because of the epithelial elements and the keratin elements that are present in skin. If the structural integrity or the tarsal plate is lost, we can use cartilage grafts that can, reconstruct the structural support. Now, these cartilaginous grafts can be either simple cartilage, or they can be composite cartilage. That is, you can have cartilage with skin, or you can just have cartilage with perichondrium. So you have different sources: nasal septum, chondral mucosal grafts, upper lateral nasal, conchal grafts, and hard palate mucosal grafts. Now, hard palate mucosal grafts do offer structural support because they're thick and they don't deform. So they come under tarsal plate replacements if you're planning to do a partial thickness repair with a graft. Now, if you place the graft, you always must have um, well vascularized bed. If you don't have a well vascularized bed, then you're not going to have graft take. And you cannot use two static grafts, obviously, because that will never take as well. Now, there are some general principles in closure that we have to follow. The important things are um, it is always better to convert your defect, your through and through defect, into a pentagonal defect, because that is what makes it easier to close. And then there are a series of sutures that you have to take, which include closure of the tarsal plate, closure of the lid margin, and closure of the skin. So in principle, you approximate the posterior lamella separately, and then you approximate the skin and the lid margin separately. You don't do them through and through. So in the posterior lamella, when you're looking at a through and through defect, the eyelid retractors are sutured first, and then you move on to the tarsal plate. Now, the tarsal plate can be sutured with vicryl stitches, but they should not be through and through bites, because you don't want the suture to go through the conjunctiva and abrade the cornea. So it should be just through the tarsal plate and extra conjunctival, and you should never have any exposed suture abrading on the cornea. Now, this is a simple example. So you have to make it a pentagonal defect. What we first do is to take a stay suture just beneath the lid margin within the tarsus, and we don't tie it. We suture the tarsal plate in a vertical mattress fashion or in a simple fashion, and we don't tie the knots until all the sutures are placed, as you can see here. Once all the sutures are placed, then the knot is tied, and once the knot is tied, the lid margin is removed, and the tarsal plate is removed. gray line of the lid. Now, these vertical matter sutures are left long because the skin is then approximated with a running stitch, and one end of the vertical matter suture is sutured to this end of the running suture, and the other end is just hooked under the running stitch. And this is done so that there are no protruding suture bits that can abrade the cornea. You always have to avoid vertical tension because vertical tension can cause reduction in the vertical height, can cause ectropion. The location of the defect, if you have a midline defect, it is quite easy to close the defect primarily. And marginal and juxtamarginal defects are also quite good to be closed primarily. If you have a lateral and or a medial defect, then you have to do additional procedures because the lid doesn't really approximate well in those circumstances. Now, the primary closure of a defect is only possible for about 25 to 30% of loss of lid. So you cannot be overzealous and close the wound under tension. So anything up to 30% of lid loss can be closed primarily by these suture techniques. And it's also important to understand what is the role of the canthal ligaments. You know that the medial canthal ligament has two slips, and one attaches to the posterior crest, the other to the anterior crest, and they encircle the lacrimal sac. The posterior limb is what gives the tension to the lower lid. Likewise, the lateral canthal ligament also has two slips, a superior crus and an inferior crus, and it just inserts into the orbital margin. Now, this is important to know because for two reasons. One, if you want to mobilize the lid to be closed primarily beyond the 20% to get more lid laxity, we have to do a canthotomy and a cantholysis, either an inferior cantholysis or a superior cantholysis, depending upon the lid that you want to close primarily. And secondly, when we do advancement flaps, which I will come to later, we have to reconstruct the medial and lateral canthal suspensions again. Otherwise, the lower lid will not have any structural integrity, or the sling of the lower lid will be lost. So, defects no larger than 25 to 30% of the lid can be closed primarily, as I had mentioned to you. You make it pentagonal. If additional mobilization is required, then you do a canthotomy. And once you do a canthotomy, you cut the lateral canthal tendon. And once the lateral canthal ligament is cut, then the lower lid moves much more. So you get another 5 to 8 millimeters of mobilization if you cut the lateral canthal ligament. Now, canthotomy and cantholysis is something that every ENT surgeon should know. So it's not a difficult procedure to do, and it really helps in mobilizing the lid, the residual lid, to be approximated primarily. Now, in cases where the lid cannot be approximated primarily, we have to consider two options, broadly two options. One is advancement flaps, and the second is switch flaps. That is how they are broadly classified. And sometimes we have to use a combination of these techniques to reconstruct both the lamella, because some of the flaps only provide tissue for one lamella, and you'll have to consider other options to reconstruct what has not been provided by the flap. So we'll start with this upper eyelid, 25 to 30% direct closure cantholysis, 50 to 75% cantholysis or use of a Tarsal flap, more than 75% Cutler beard flap or a modified Hughes flap. In the lower eyelid, 25% is direct closure, 25 to 50% is cantholysis or a Tarsal flap, and more than 50% or 70% we can use a Hughes flap. I will describe the flaps in the subsequent slides. Now, I'd mentioned to you that if you have a central defect, it's quite okay to approximate it primarily or do a canthal release and then approximate it. But in some instances, we may not be able to do that. Even with the canthal release, we may not be able to do that. So in order to reconstruct the sling, or in order to reconstruct the lateral canthal suspensory mechanism, we can harvest a periosteal flap that is based on the orbital margin, as you can see in the picture here. This is usually 5 millimeters wide, and it is dissected over the bone here and reflected 180 degrees, and that is sutured to the tarsal plate. Now, this tendon can act as the posterior lamella, and you can do a simple procedure like a temporal skin flap where you incise the canthus and advance the skin, and that provides the anterior lamella. So for a lateral defect where you need to reconstruct the suspensory mechanism, you can raise the periosteum, leaving it attached to the orbital margin, which is 5 millimeters wide, suture to the remnant tarsus on the lid, and then advance the skin flap over it to close the suspensory, neo-suspensory mechanism. Now you can use this even for larger defects. Now, what are the options that we have in case you don't want to do full thickness skin graft? Let's say that the posterior lamella is intact or the orbicularis is intact, but you're still not keen on doing a full thickness skin graft. There are some options that we can use by borrowing skin from the local site. One is a freaky flap, where you can take a laterally based skin flap from just above the eyebrow. It is dissected out and just flipped over, and the defect is closed, and this is closed primarily. In some cases, a VY advancement for small defects can be done. And the trippier flap is a bipedical flap that is taken, that is skin from the either the upper or the lower lid, but traditionally described as a switch from the upper to the lower lid. And this is quite okay if you don't want to do a full thickness skin graft, but you want to borrow skin from adjacent sites. Now coming to the advancement flaps. So these flaps are what are most commonly used. And one of the earliest described advancement flaps was the Cutler beard flap for upper eyelid defects. Cutler beard was described in 1955. And there is some controversy about the Cutler beard flap because some textbooks and some literature will tell you that it is a purely, um, you know, a flap that does not include the tarsus, whereas some papers would say that it is an advancement of the full thickness of the segment of the lower lid. But there is some confusion there. But the traditional description is that it is just the skin and the minimal subcutaneous tissue without the tarsal plate. And to give support, we have to use an additional cartilage graft to be placed between the layers of the Cutler beard flap. So how we raise the Cutler beard flap is that we make an incision for 3 to 5 millimeters below the lid margin on the lower lid. Then the conjunctiva is also incised. Now the conjunctiva is dissected up to the fornix and up to the orbital margin. The skin is taken under the skin bridge, taken to the upper eyelid, which is present there, and then the skin is then closed to the defect, and this will result in a closed eye for the patient, because you have to wait for this bridge of skin and subcutaneous tissue to draw blood supply from the upper lid. And usually it is kept occluded for 6 to 8 weeks. And after 6 to 8 weeks, we divide the bridge of skin here and then suture the lower lid remnants back to this margin, and the upper lid skin margin is kept slightly everted to prevent the corneal abrasion. Like I mentioned, the traditional description does not mention it to be a tarso-conjunctival flap, but it is quite confusing because some books and some literature does describe it as a through and through incision, because it makes sense that the lower lid tarsus is much shorter than the upper lid tarsus. So I don't think if you raise a skin flap like this, you're going to incorporate any of the tarsus of the lower lid, and any compromise of the lower lid tarsus is going to cause vertical shortening of the lower lid. Now, this is an example of how the the cutler beard is combined with a cartilage graft. So you first put the conjunctival flap in place, then you put a ear cartilage in place, and then you suture the skin to the skin defect. Now this ear cartilage is between two vascularized pieces of tissue. And then after 8 weeks, you divide the bridge of skin, and then you have the neo upper lid and the resutured lower lid. So this is probably the traditional cutler beard that was described, but again, there is some controversy with its description. This is an example of a cutler beard done for a almost total upper eyelid loss. As you can see here, the flap that we raise does not include too much of the tarsus. It's just the skin, subcutaneous, and some of the orbicularis muscle. And then there is suture to the upper lid defect. And you wait for 6 to 8 weeks before dividing the bridge of skin and opening the patient's eyes afterwards. Now, the problem with the cutler beard is that you don't reconstruct the lid margin. We don't reconstruct the eyelashes. You don't reconstruct the secretory margin of the lid. That is not done. So switch flaps were described by Mastade in the 1980s. And the advantage of a switch flap is that you bring like tissue to replace like tissue. And large defects also can be repaired. A lid margin is obtained. Now, if you look at the blood supply of this is for upper eyelid defects. If you look at the blood supply of the lower lid, the medial blood supply is from the angular artery and the nasal arteries, whereas the lateral blood supply is from the superficial temporal artery, and there is an arcade. Now, the flap that is most vascular is a medially based lower lid switch flap because the vascular supply is more robust. And you have to keep the incision well beyond 5 millimeters to preserve the arterial arcade of the lower lid. And it's just like an Abbey flap. It is just twisted and sutured to the upper lid. But there is shortening of the lower lid because of that. And then there are some secondary reconstruction procedures that need to be done. The picture on the left is a laterally based flap. As I mentioned, the vascularity of the laterally based flap is not as good as the medially based flap, but these flaps are seldom used nowadays with the advent of the advancement flaps probably are more commonly done than the switch flaps. Now, if you have a defect which is slightly bigger, which you cannot close by primary primary closure or by cantholysis, then Tenzel has described the semicircular flap, which can be used both for upper and lower eyelid. So you can reconstruct up to 70% defects of the upper and lower eyelids. Now, basically, if you have a lower lid defect, you mark a skin incision which goes in a semicircular fashion, and the width of this is about 2 to 3 centimeters, and it is just below the eyebrow. You do have to release the canthal ligament, and you have to undermine the skin, uh, it's a myocutaneous undermining. So you'll have to undermine the orbicularis muscle also. And once this is undermined, the lid is then approximated to the cut end on the other side. When you do this, you have to remember to resuspend the lateral canthus by taking a stitch through the periosteum. And the problem with the Tenzel flap is that you're only reconstructing the anterior lamella. You're not reconstructing the posterior lamella. So if you want to reconstruct the posterior lamella, you can use a periosteal strip, as I showed you earlier, or you can take a tarso-conjunctival flap from the upper lid and turn it around into the lower lid and reconstruct the posterior lamella. You have to be very careful of resuspending the lateral canthal support. Otherwise, the lower lid will not have any, will lose its sling mechanism. If you have an upper lid defect that you have to close, the semicircle is in the opposite direction, but the principle is the same. You have to undermine the skin deep to the orbicularis. you cut the lateral canthal crust, you mobilize the skin and the tarsal plate, and then you suture it to the remnant upper eyelid and reconstruct the posterior lamella with a tarsoconjunctival flap from the lower lid. So this has to be done, otherwise the patient might have problems with corneal aberration. So there's some facts about the tensile flap that you must remember. Up to 70% of defects, the defect length can be closed with the tensile flap. But the important thing is some remnant tarsus should remain on either side of the defect. That is very important if you want to try and do a tensile flap. And there is no eye closure. So if you look at the Hughes flap or the Cutler beard, the patient will have his eyes closed for 6 to 8 weeks. So if he has poor vision in the opposite eye, it will be a problem for him to manage his day-to-day activities. So it is in a way good for people who have poor vision in the opposite eye because it eliminates the need for closure of the eye. Now, just like how the Cutler beard is a good flap for large defects of the upper eyelid, that is more than 70%, the Hughes flap is a good flap for reconstructing defects of the lower eyelid. So when there is 50 or 70% of the defect of the lower eyelid through and through defect, we can use a Hughes flap. It was described way back in 1937, and the this flap is primarily described for reconstructing the posterior lamella. You must remember in the Cutler beard, you're reconstructing the anterior lamella, the classical Cutler beard, you're reconstructing the anterior lamella. Whereas you do reconstruct the conjunctiva as well, but you don't reconstruct the tarsus. But here, this flap is purely for the posterior lamella. So what you do in a Hughes flap is you make an incision uh, in the upper lid, and this incision is deepened to the tarsus, and on the other side of the tarsus you will see the orbicularis muscle. The dissection is done all the way to the orbital ridge, where you will see the levators of the upper eyelid, that they have to be preserved. Then you take this tarsoconjunctival tissue which you have raised from the upper lid, and then you suture it, you flip it 180 degrees, and you suture it to the tarsus of the lower lid, the remnant tarsus of the lower lid, and then the orbicularis muscle can be skin grafted. Now this follows the same principle as that of the Cutler beard, where you have to wait for 6 to 8 weeks before you can divide this bridge of skin. And once the bridge of skin is divided, you have to transect sharply the upper lid here. And then you always keep the conjunctiva about 1 to 2 millimeters longer to avoid entropion. And using a Hughes flap, you can reconstruct very large defects of the lower eyelid. The only problem is that this is primarily a posterior lamellar reconstruction, and you will have to skin graft the outside of the orbicularis muscle. Now, another flap which is not being used that commonly is mustardi. So if you have defects more than 75% of the lower lid, you can use a cheek rotation flap, otherwise the mustardi's flap. In the mustardi's flap, you have to extend the defect. You'll have to cut more, inverted cone of tissue from the lid margins. And then you raise a skin flap which goes along the cheek and then curves inferiorly preauricularly. Now this is undermined till about 1 centimeter to where the defect is, and then this is then slid over and sutured to the remnant lid margin medially. Some sort of posterior lamellar reconstruction has to be done again, and it's only an anti-lamellar reconstruction that you're doing. The posterior lamellar reconstruction is by nasal septal cartilage or hard palate mucosa. There are several technical aspects to be considered, and this is the same technical aspects that you will consider when you're planning a mustardi flap for a cheek defect. but it's seldom used today because of the other techniques that are more commonly employed. This is an example of a Mustardes flap. So if you have a lateral lid defect, which is not much, then you can use the Mustardes. If it's a central defect or a medial defect, then you're better off using some other flap to reconstruct the anterior and posterior lamella. Now, another peculiar problem is the medial canthal defects. So for medial canthal defects, we can borrow tissue from the glabellar region, or we can borrow tissue from the forehead. Now, the glabellar tissue is quite okay because you can just mark the flap, and then the flap has a transposition moment like a Limburg flap, and then it sits quite well in the medial canthal defects. And the flaps can be longer, extended into a forehead flap if part of the medial lid also has to be excised. Now, the medial lid area has got several components, especially the lacrimal apparatus, the pump, and things like that, the sac. So you have to have a plan in mind how you're going to keep it canalized, and you have to address that issue as well. But here, always try to preserve the posterior attachment of the medial canthal tendon to the posterior crus, because that is what gives structural support to the lower eyelid. If you don't have that, then you have to take sutures through the periosteum or do transnasal wiring, whichever is more comfortable. Otherwise, the patient will have telecanthus. So tissue from the glabella or extended forehead flaps are quite okay for medial canthal defects to reconstruct the medial canthus and the adjoining lower lid. This is another example of a small flap that is raised from the medial part of the root of the nose. And these local flaps are better because the donor site also is closed primarily, and there is no tension on the wound edges. So coming back to the original slide that I had shown you, upper lid, 25 to 30% is direct closure or cantholysis. 50 to 75% is cantholysis or a tensile flap. More than 75% is a Cutler beard flap. The lower eyelid, 25% is direct closure. 25 to 50% is cantholysis tensile flap. And more than 50% is a Hughes flap. So I've tried to keep this presentation simple because the only flaps that you need to really master are the tensile flap, the Hughes, and the Cutler beard. So the defect size dictates the choice of flap that is used. The options are between advancement flaps and lid switches. Advancements are more commonly used now than lid switch flaps. You have to aim to maintain the vertical height of the lids to avoid complications. Recreate the medial and lateral canthal suspensions of the lower eyelid. And another important thing that you should always remember is when you're reconstructing the tarsus, you have to suture the remnant levators of the upper lid, namely the levator palpebrae and the Muller's muscle to the neotarsus. Otherwise, the patient will have ptosis of the eye, especially if his Bell's phenomenon is inadequate. So you have to resuture the cut end of the remnant levators to the neotarsus to prevent ptosis. So that is the end of the first presentation on lid reconstruction. Should we take questions now, or do you want to finish the lip reconstruction and then get back?
Hello, sir. There are only just a bunch of questions. So can I ask questions now itself? We'll clarify and go to the next topic.
Yeah.
So the first question is by Dr. Vinayak. His question was, all the orbital flaps which you have mentioned are only for the malignancy, or can it be used for trauma cases too?
So it's the same principle. Usually for trauma and laceration, most of them will be, you can use them, you can close them primarily or by cantholysis, but I don't see a reason why you can't use them for loss of eyelid following trauma. In fact, it's easier to place composite grafts or tarsal support because the patient won't be receiving any radiation. So I don't see any reason why it cannot be done for trauma cases.
Okay, sir. So the second question is again by Dr. Vinayak itself. Could the ectropion be caused by the stretch flap?
Could the what? Sorry. Yeah.
Ectropion be caused by switch flap.
No, the switch flap will narrow the because you're borrowing from the lower lid to the upper lid. The amount of lower lid is reduced, and the width of the palpable fissure, that is, the transverse segment of the palpable fissure, is smaller. I don't see a reason for it to cause ectropion, but it will cause some disturbance in the palpebral fissure. So the eye, the opening of the eye will tend to be smaller compared to advancement flaps.
Okay, sir.
Ectropion is only caused when there is excessive lid laxity and there is no tarsal reconstruction.
Okay, sir. So the third question is by Dr. Nikita. In the mustard flap, what is the lymphatic drainage of the flap?
It's only dermal lymphatics. The important thing, I just saw a question. The important thing about the Mustardius flap is because by gravity, it tends to gravitate inferiorly. It tends to pull the suture line and gravitate inferiorly and cause ectropion. That is why the flap has to be hitched to the orbital wall. So you have to take periosteal stitches to the subcutaneous tissue of the Mustardius flap and then suture it to the orbital, the orbital walls, lateral orbital wall. So that will prevent that. And lymphatics is just dermal lymphatics. I don't think there's any specific lymphatics for the Mustardius flap.
Okay, sir. So the next question is by Dr. Ira Nina. How do you reconstruct the nasolabial duct if we need to excise the medial canthus?
I mean, you get the help of your ophthalmology colleagues, see if they can cannulate the duct. But in cases where the floor of the medial orbital wall is removed, then if you're doing a maxillectomy or a procedure like that, you create a dacrocystostomy anyway. Otherwise, you get help from your ophthalmology colleagues to cannulate the nasolacrimal duct and keep it patent. Usually, when you do lid excisions, you don't take out the nasolacrimal duct as such. It's only the skin and the tarsal plate and the medial end of the eyelid. It's only if it's along with medial wall of the maxilla or medial wall of the or lateral wall of the nose. There, you're obviously creating a huge dacrocystostomy. So I don't think there is much to worry in those cases. Otherwise, you get the help of your ophthalmology colleagues and cannulate the nasolacrimal duct.
Okay, sure. So the next question is from Dr. Abhimanyu. He's asking your experience on posterior lamellar reconstruction. Which is better, periosteum or buccal mucosa or hard palate?
So for lower lid, you can use the periosteum because that will also give you some suspensory support because it's attached to the orbital rim. But if it's not the lower lid, if it's in the midline, if the tarsus is intact, I mean, if the canthal ligaments are intact laterally, then you can just use hard palate mucosa or buccal mucosa. It doesn't really matter. The hard palate is a little more firm, so you'll get some structural support also. Otherwise, buccal mucosa is fine. You can use buccal mucosa also. There's no real specific preference.
Okay, sir. So the other question is from Dr. Nahib. Sir, which tissue is best for tarsal plate reconstruction?
So the best tissue for tarsal plate reconstruction is the tarsal plate itself. So if you're doing a Hughes flap, you will do it. So if you do any tarso-conjunctival flap, like the Hughes flap, replacing like with like, that will be the best form of reconstruction. But if you're doing it as a static graft, you can use nasal septal cartilage or conchal cartilage. Both work fine. They just have to be trimmed to size for the defect and sutured to the remnant tarsal plate in the defect. Otherwise, it will tend to deform. And always remember, you should have a vascular surface surrounding the cartilage grafts. Otherwise, the cartilage grafts can undergo necrosis.
Okay, sir. I think we'll take the last question for this orbital reconstruction, sir. So, what is the time for nasolacrimal duct decannulation, and how long do you keep it the probe inside?
I really don't know the answer because I usually send the patients to the ophthalmologist after that.
Okay.
But Usually the cases that I've done, there's a defect in the floor of the orbit. So I have never had to recannulate it per se.
Okay,
But
sir.
probably, I don't know, the ophthalmologists are probably the better people to answer that question.
Okay, sir. So, sir, we will go to the lip and then we'll, at the final end, we'll take all the questions again, sir.
Yeah, that's fine. Is the PowerPoint
Yes,
visible?
sir, it's visible, sir.
Yeah. So the second relatively uncommon reconstruction that we practice is lip reconstruction. Now, lip reconstruction for many reasons is quite challenging because the lip is a far more complex structure than it appears. The lip is not only part of the aesthetics of the face, but it's also functionally important because it is part of the oral sphincteric mechanism. There are several ways to reconstruct the lip. You either borrow tissue from the lip itself or you borrow tissue from the adjacent sites. And the location and the size of the lip defect dictates what flap we use. So the things that we have to consider in this presentation are the relevant anatomy of the lip, the aims of lip reconstruction, how do we classify lip defects, what are the reconstructive options for lip defects, how do we do commissure reconstruction, total reconstruction of the lip, and what are the problems and outcomes of lip reconstruction. So before we begin, we need to have a sound knowledge of the lip anatomy and its function. And we also have to remember about or keep in mind the remarkable distensibility of lip tissue, meaning that we can quite easily get away by distending the residual lip or using borrowing lip from the opposite side to fill in the defects. We also have to understand how small the oral sphincter can get but still be functional. We have to understand what are the local and regional tissue transfers that can be done for lip reconstruction. And always have plan B for lip reconstruction because these tumors tend to recur and you must be familiar with free flap transfer techniques, which are also useful for massive defects of the lip. So if you look at the lip has several distinct landmarks. You have in the upper lip, you have the philtral columns, the philtral groove. You have the white roll, which is most distinct in the central area. You have the cupid's bow and you have the tubercle. And the lower lip is usually generally featureless and it's got a very wide vermilion, which is widest in the central lip. Now, regarding distensibility, in the lower lip, up to 40% of the lower lip defects can be closed primarily, and up to 25% of upper lip defects can be closed primarily. Some books and literature tends to argue to the fact that it's only 25% for both lips, but the lower lip is slightly more amenable for primary closure compared to the upper lip. Now, the lip is not a simple structure because it's not the orbicularis oris alone that is a part of the lip. Several other muscles of facial expression also attach to the lip. And one of the most important aspects that we should remember is when we do lip reconstruction, we must not disturb the modulus, which acts as a central point trying to anchor all the muscles of facial expression. So whatever lip reconstruction you attempt, try not to disturb the modulus if possible. Now the lip in cross section is a trilaminar structure. So you have the mucosal surface on the inside, you have the labial artery after that, then you have the orbicularis muscle, then you have the skin with its subcutaneous tissue. Now you must always remember the position of the labial artery because this is what will help you when you're planning for your lip switches or lip advancements. It's on the inner aspect of the lip or the mucosal aspect and not on the outer aspect. So when you're planning for incisions for lip reconstruction, remember the aesthetic lines of the face, remember the distensibility of the lip, the upper lip has two aesthetic subunits, whereas the lower lip has only one aesthetic subunit. And remember not to cross the aesthetic lines when you plan your incisions. So how do you optimize results in lip reconstruction? So there are some key factors that you must consider and remember when you're planning lip reconstruction. One is respect the aesthetic lines on and around the lips when you're planning the incision. Mark the white roll because proper alignment of the white roll is most important for lip reconstruction or when you're primarily suturing the lip. Depending upon the laxity, the lip can be closed primarily or tissue can be borrowed. When you're doing a lip switch procedure, always try to occlude the pedicle to ensure vascularity. I will show you pictures about that. When there is not enough tissue from the same or adjacent lip, the next best choice to recruit tissue is from the cheek. Don't divide muscles attached to the modulus. And if you're doing a radial forearm flap, perform an Allen's test before harvesting the flap. So in a nutshell, if you look at lower lip defects, because they are the most common defects that we encounter, if you have less than 1/3 defects, you can do primary closure either as a wedge, as a W-plasty, or a bilateral advancement flaps. If it's 1/3 to 2/3, if the defects are medial defects, use Karapanic, a bay, or a staircase flap. If the defects are lateral, then you have to consider one important factor. Will your flap cause microstoma or not? Because if you have lost a lot of lip tissue and if you attempt a flap which causes microstoma, you defeat the purpose of reconstructing the lip. So if the microstoma is unlikely, meaning you have enough tissue that will cause a wide oral opening, mouth opening, then you can consider the Eslander, Karapanic, or a staircase flap. If you have lost a lot of tissue and microstoma is possible if you try to do flap reconstruction, then you should consider a Gilly's flap or a nasolabial flap. When you see massive defects that is more than 2/3 of the lip, then you have to recruit tissue from the cheek that is called the Webster-Bernard flap. And when there is no local tissue available and you wish to reconstruct the lower lip sling, then you have to look for distant flaps for reconstruction. So it is very simple, less than 1/3, the third to 2/3, again medial and lateral, and more than 2/3 whether you have local tissue available or not. Now you have to be able to calculate the lip stock. See, the total lip length is about 15 to 16 centimeters at rest. The upper lip is larger than the lower lip by 1 centimeter. If the oral sphincter is considered to be a circle, simple geometry dictates that its diameter is equal to its circumference divided by pi, which is just over 5 centimeters. But the oral sphincter is not, the oral sphincter is actually oval. And the calculated distance is more or less taken as a normal oral opening. So it means that the intercommissural distance should be about 5 to 6 centimeters for you to say that the patient has got a normal oral intercommissural distance or a normal space between the two commissures. So what happens if you need to maintain 3 centimeters of mouth opening? That 3 centimeters basically is what will allow a spoon, a width of a tablespoon, to enter the mouth. So anything less than an intercommissural distance of 3 centimeters will functionally, debilitate the patient. So you have to have a minimum of 3 centimeters mouth opening because then you can use a spoon to eat. So if you lose 6 centimeters of both the upper and lower lips, then a 3 centimeter tissue will be only available if you don't import any other tissue. So if you lose 6 centimeter or more of lip tissue, combined upper and lower lip tissue, it's always good to import tissue to maintain the intercommissural distance. And if you want to maintain a 3 centimeter opening, you need to have about 9 centimeter of lip stock. So let's look at partial thickness defects first. The table that I showed you earlier This is for lower lips which are through and through defects. So this is just to get the ball rolling on the flaps that we do. But those are for through and through defects. But to begin with, let's look at partial thickness. So partial thickness defects mean that the underlying muscle or the underlying lip structure is intact. So you can just have defects which need lip resurfacing, that is vermilion defects, or you can have defects of the skin, which are cutaneous defects. So if you have a vermilion defect, you can do an advancement or myomucosal switch flaps or FAM flaps. If you have cutaneous lip defects, then we can do advancements and transpositions. And sometimes if you have a very small partial thickness defect, it may be okay to convert it to a full thickness defect in men because the hair and the beard can camouflage the scar of the full thickness defect. So these are some of the examples of partial thickness where the vermilion and the mucosa is lost. So you can do a vermilion switch. You can do a bipedical vermilion transfer, or you can do a vermilion advancement here. So the problem here is if you use a vermilion advancement, the lip tends to be more rounded, more red, and more recessed. But it's always better to reconstruct the mucosal defects by either advancements or a vermilion switch or a bipedical vermilion transfer or vestibular mucosa transfer, because they are replacing like with like, that is secretory mucosa. If you have cutaneous defects, you can try doing advancement flaps, so or VY advancements, as you can see here, or if it's in the area below the lip, you can do a nasolabial flap in certain instances to close cutaneous defects. But this follows the principle of any cutaneous defect reconstruction, and these are also quite rare, considering the fact that there are lip tumors which extend to the skin, and they have to be treated as one unit. So isolated cutaneous defects may be rare in lip tumors. Now, what are the types of excisions that facilitate closure? It's not just a straight wound margins which will allow you to close it primarily without tension and with proper aesthesis. You can do a wide variety of extensions to your incision. You can use a flared W, you can do a single barrel, you can do a double barrel, or you can just do a wedge-shaped excision. And if you do these excisions, the resultant scar will be much finer and much more aesthetically pleasing. So you have to do preoperative planning when you're trying to excise these tumors through and through. Now, if you have a defect that you wish to close primarily, and the defect isn't approximating in the midline, then you have to give releasing incisions and remove intervening skin bridges. So these are some things called perialar crescents, where you remove the skin and subcutaneous tissue, and you have labiomental excesses in the chin area where the labiomental crease exists. So if you remove the perialar crescent, this will become a flap here, and this perialar crescent will allow this to become a flap and facilitate approximation. And for the lower lip, you can use the labiomental excess. So if you need to release tissue to make it advance, use a perialar crescent for the upper lip and use the labiomental excess in the lower lip by removing that piece of skin and subcutaneous tissue, and the lips can be approximated. This is a flap that I use if I have a midline lower lip defect. This is called a stepladder flap, which is exactly what the word indicates. You make an incision in a stepladder fashion and remove the rectangular piece of skin and subcutaneous tissue in the areas of the steps. And once this is moved, these steps override each other and the lip will also meet in the midline. And this scar is hidden by the labiomental crease. So this is quite good for midline lower lip defects. I mean, you can always use the labiomental excess and incise and then advance it, but this allows for slightly more movement of the residual lower lip, and then the residual scar is also aesthetically hidden along the labiomental crease. So we had seen partial thickness defects where we used vermilion mucosa, vestibular mucosa. We looked at how to plan small defects, small excisions in a W or a single barrel or a flange. Also, we looked at how to excise perialar tissue or labiomental tissue to make advancement flaps. But what if the lip defect is not amenable to primary closure? So large lower lip defects, we either borrow from the lip or we recruit from the cheek. So borrowing from the lip again depends upon the location of the defect. If you have a medial or a lateral defect, probably lateral defect is probably more in tune. You can use an Abbé flap, but if there's a lateral defect which includes tissue, then an Islander flap is used. If you don't have tissue to borrow from the upper lip, then you recruit from the cheek. If it's a central defect, you can use a Karapanic, a Bernard, or a Gilly's flap. So you have to decide upfront if you're going to borrow from the lip or you're going to recruit from the cheek. The Abbé flap is the most commonly described flap for lip-to-lip reconstruction. Now, the Abbé flap is based on the labial artery. What we basically do is take a triangular piece of tissue, which is the part of the upper lip, and this is turned and sutured to the lower lip defect, and the upper lip defect is closed primarily. Now, for a period of 6 to 8 weeks, there is the intact pedicle that is present here. And this pedicle is what perfuses the flap for the initial few weeks until the flap draws its vascularity from the surrounding tissue. It is good because this flap offers maximum probability of return of sensory function. And an Abbé flap can be either a medially based Abbé flap or a laterally based, meaning either you have the blood flow coming from the medial aspect or you can have the blood flow coming from the lateral aspect. And there is a difference between the two when it comes to the interim functional outcome. So if you have an ipsilaterally based pedicle, it creates a very small stoma on the index side and a reasonably large stoma on the opposite side. If you use, and it's slightly harder to rotate. So if you have an ipsilaterally based pedicle, it's easier to eat with when a patient does not have to struggle with eating until the pedicle is divided. If you have a contralaterally based flap, it's easier to rotate, but it creates two small sized openings and it makes it difficult for the patient to eat before the pedicle is divided. So an ipsilaterally based Abbé flap is a good option for defects which are 1/3 to 2/3 of the lower lip. And the ipsilaterally based flap also allows for acceptable eating during the period that the pedicle is not divided. Now, prior to the division of the pedicle, you can always occlude the pedicle with a rubber tourniquet or a piece of gauze to see for vascularity of the flap by pricking it. Only if the vascularity is confirmed should the pedicle be divided. If the vascularity of the flap is not sufficient, then we have to wait for a few more weeks till it gets reliably perfused from the surrounding tissue and the pedicle then is divided. The Islander flap is the same principle as the Abbé flap. You base it on the labial artery, but it's for resections which involve the commissure. The problem with the Abbé flap is that it creates a rounded commissure, and as with the Abbé, there is no addition of lip stock. So you have to remember that you're not providing the lip with more tissue, and we should not get below the minimum 9 centimeters total lip stock. That will make the patient functionally crippled. So these lip switches do not offer any additional lip stock for reconstruction. The Gilly's flap is another flap that can be used if the defect is in the midline. It's a full thickness incision and it pivots around the commissure. And it can be done for both the upper and for the lower lips. It also results in a more rounded commissure. But the problem with the Gilly's flap is Because it's a through and through incision, it is a de-innervated flap. There is no sensation on the lip or the commissure, and it's largely been replaced by the Karapanic flap. Now, the Karapanic flap is, an advancement flap where we don't add anything much to the lip stalk again, but we have to use incisions on the cheek, which are not through and through, thereby preserving the neurovascular integrity. The incision is through and through here at the lip level, but as you go further, you have to make sure you preserve the neurovascular bundle before giving the complete incision. And the two flaps are advanced, and they're sutured in the midline. Now, this is a problem with the Karapanic. The Karapanic flap creates a microstoma because you don't add any lip stalk to these patients. So because of this, the patient becomes functionally a cripple, and they cannot eat uh, without the help of a spoon. But the advantage of a Karapanic is that it is a innervated flap, and hence the lip is a sensate lip. So this is a large lip excision where the skin of the mentum also is excised. This is a Karapanic flap which is raised on both sides, brought to the midline, and then the skin was undermined and closed. So very large defects of the lip can be closed, but in most cases, it will end up with a microstoma for the patients. And remember, at the commissure level, do not damage the neurovascular bundle to preserve the sensory supply to the residual lip. Now, for even larger defects, if it's more than 2/3 of the lip, then we have to recruit tissue from the cheek. And Webster Bernard is one of the flaps that has been described. Now, as I mentioned earlier, where you incise and take out a piece of perialar crescent, you have to take out triangular pieces of tissue to facilitate movements and advancements of these flaps. So there are many versions and updates of the Webster Bernard. What we do is for the lips to move and meet in the midline, we give releasing incisions on the cheek, take it up to the nasolabial area, and remove a piece of skin here to facilitate the advancement. And we also take the incision down to the um, mental crease on both sides. And this is undermined to full thickness. And then the lip is brought into approximation. There is some augmentation of the lip tissue because we are borrowing a tissue from the cheek, but it's largely static tissue because it does not contain the orbicularis muscle, and hence it's only a static reconstruction and not a dynamic reconstruction. So this is another example where you have taken away triangular pieces of tissue, triangles of tissue and subcutaneous tissue, skin and subcutaneous tissue. You have made releasing incisions along the mental crease and the mental protuberance. And then you have raised this as a flap, raised the other side as a flap as well. This is a raised flap that you can see, and then the flap approximated in the midline. So this is a typical way the Webster Bernard is done. Unfortunately, there is not too much augmentation of the lip stalk, but it's certainly better than what we would do with a Karapanic flap. This is a picture that I'd shown you earlier. The nasolabial flap can also be used either for one-sided defects or for total lip defects. But again, these tend to sag with time, and the vertical height of the lower lip tends to decrease with time. It's also a static reconstruction. There is no sling, and the oral commissure may not be as good as compared to a radial forearm with a palmaris sling. Now, if you want to do a total lip, lower lip reconstruction and you want to make it dynamic, there are several factors of the defect that we have to consider. We have loss of volume and shape. We have loss of the lip height. There is no vestibule. There is no sphincter. The flap, whatever flap that we put in, is going to be insensate, and it's very difficult to predict the long-term result. So this is a patient who had a total lower lip resection and marginal mandibulectomy also. And all these factors are important to consider when you're planning for total lip reconstruction, especially with a free flap. So the ideal flap to use in these circumstances is the radial forearm flap. So part of the flap covers the skin and the other part of the flap covers the mucosa lining on the inside. The first picture shows you a free palmaris tendon as a sling. Now this tendon is taken around the commissure and if possible sutured to the upper lip near the midline, and a subcuticular tunnel is made on the flap, and the flap is and the palmaris is suspended under the subcuticular tunnel, because if you suspend it under the pedicle, the flap will necrose. So you've got to create a subcuticular tunnel the palmaris tendon, take the palmaris tendon to the upper lip so that it forms a circumoral sphincter, and suture it to the muscles of the upper lip. And then the pedicle is taken to the neck and vascular anastomosis is performed. Now, this doesn't look aesthetically pleasing because you have not reconstructed the mucosa. Over time, this lower lid tends to sag down even if you have reconstructed the sling mechanism. There is no real optimal way to adjust the height of the lower lip. But it's always better to overcorrect, taking into account the um, decrease in the vertical height of the lid with time. And this is probably the best way to reconstruct a total lip through and through defect where you want to reconstruct the sling as well. Now, the last part is the commissure reconstruction, which is very complex. And it is the most important aspect of lip reconstruction. Most scars can be hidden of the commissure, but you cannot hide drooling of the of saliva at the commissure area. So you've got to remember that. And there are some flaps which will automatically correct the commissure, like the Islander. But there are some other flaps which have been described for a long time. That is a Zisser and the Brusati's flap, which are used for commissure reconstruction. And as I'd shown you in the pictures earlier, if you have a contiguous defect, a radial forearm flap with the sling is ideal in these circumstances. The important thing to remember is the commissure position, and they're based on the Wright's facial landmarks. Usually the commissure is at the mid-pupillary line. So when you plan to reconstruct the commissure, always keep it in line with the pupil of the patient. So if you have resection of a tumor at the commissure area alone, we can use an advancement of the cheek skin, and you can also use the mucosal flap from the buccal mucosa. This is called the Zisser's flap. And in the Zisser's flap, you also deepithelize part of the skin that you're advancing to give bulk to the commissure, and then you advance the mucosa to suture the skin and the mucosa together. And this is probably good for isolated defects of the commissure, which does not involve the lip. If it involves the lip, then you go ahead and do an Islander flap for the patient. The Brusati's flap is better for defects which are horizontal compared to the Zisser's flap. So here also you can see that the triangles of skin have been removed. The flap has been elevated here. This is where the defect is going to be. The flap is then advanced into the commissural defect. The skin here is incised and turned over, and a new commissure is reconstructed. So the Zisser and Brusati are the two flaps that we use for isolated commissure reconstructions, but it's very rare to find tumors which only have isolated commissure involvement. But even if you do, then these two flaps are probably good options for commissure reconstruction. There is another flap called the orbicularis oris flap. So if you have to reconstruct the commissure, and this is a patient who's had a large ALT flap which was sutured to the commissure, in case you want to reconstruct the commissure, the lip can be incised at the level deep to the orbicularis muscle. And because the muscle can be distended and pulled, it is a sort of advancement of the muscle into the defect. So an orbicularis oris advancement flap, this has been described a long time ago, but is useful if you're doing secondary procedures where you can advance the orbicularis muscle along with the overlying mucosa and insetting it into the neocommissure. Now, because it has muscle, the muscle will unite with the muscle of the opposite side and will form a sphincter in due course. But for large lip and commissure defects, there is no other option but to use a free flap. So the same principle applies. You can take a radial forearm flap or an ALT flap, use a facial sling, a subcuticular tunnel is made. You can use the palmaris longus tendon. If it's not long enough, you can harvest strips of fascia lata. You have to take the sling to the midpoints of the upper and lower lip, and you have to tighten it considerably. It's better to be a bit tight, and suture to the midpoints of the upper and the lower lip. And this gives a competent commissure, and this allows for patient to be able to eat without much drooling. This is another example, and this is what I meant by the subcuticular tunnel, or the subcutaneous tunnel, where the tunnel is made between the vascular pedicle and the skin and subcutaneous tissue. Because if it goes deep to this, you're going to compress the vascular pedicle, and the distal part of the flap will necrose. Now, there are several problems to having a cheek, commissure, and lip reconstruction. It's very difficult to get the final position in the right place. It's very difficult to get the height in the right position, because the patients will have radiation and scar and contraction and fibrosis. It's difficult to decide on the tension of the sling. And the commissure area will always have a skin line portion, because that is the intervening part between the extramucosal and the mucosal paddles of the radial forearm. So the approximation here at the commissure also is an area that you have to be careful. So it's not a very perfect reconstruction, but patients more or less are functionally okay using a radial forearm with a palmaris. It's not uncommon to see patients who have large cheek tumors where large parts of skin have to be involved, have to be excised. We have to be clear about the goals of reconstruction and have reasonable expectations. And we always have to be prepared for doing a secondary reconstruction for these patients. So here, just using an ALT flap and planning for a secondary commissure correction is quite okay, because you have to take into account the healing for the patient, the longevity of the patient, the disease-free interval of the patient, and then you can always de-epithelize this portion of the skin, use a sling, and reconstruct the commissure for these patients. Sometimes a combination of flaps have to be used. So this patient has a lip defect, a lip tumor which is extending to the cheek. So you can use a combination of a submental flap for the cheek and the nasolabial flap for lining the inner aspect of the lip, or an abbé flap for the lip reconstruction. So a combination of local flaps also can be done. You don't have to do double free flaps to reconstruct composite defects of the cheek and lip. Even local flaps can be done, as is shown here, to get a reasonable outcome. But again, the commissure is an area of problem, and you have to be prepared to do secondary commissure procedures in the future to get commissure competence. So microstoma or macrostoma, the question is always a big problem to answer. Macrostoma is functionally more debilitating because of oral leak. There are several techniques to correct them. Microstoma can be corrected by the release and advancement of cheek skin and buccal mucosa, and macrostoma can be corrected by de-epithelializing the skin or whatever flap that we have used, and then using a palmaris tendon. And it is very difficult to achieve primary competency in the primary setting unless we opt in for a more tight commissure and for microstoma. So there are several bad cases, patients who have had both radial forearms taken with still lip defects that are bad, but we can always make use of the local tissues that are available, follow principles of skin reconstruction and local flap advancements, and you can always find a way to reconstruct even grossly debilitating defects such as these. So in the end, always try to replace like with like. If you have enough tissue to recruit from the adjacent lip, please do that, because that is the most likely way of getting a sensate lip back to the patient. Always remember never to compromise on lip stock. Have adequate lip stock to ensure an intercommissural opening of at least 3 centimeters. If you have microstoma or macrostoma, or if the patient has commissure incompetence, be prepared for secondary procedures. Local flaps are the mainstay for most of isolated lip reconstruction. And if you have large defects, a combination of flaps can be done to close the different subunits of the defect. Thank you very much.
Thank you for the lucid presentation, sir. So, shall we take the question, sir?
Yeah, that's fine. Yeah.
Yeah. So, the question by Dr. Suma Thapa is, what is modulus?
What is modulus? Is the part of the cheek where the muscles of facial expression are all attached to. It is just lateral to the commissure, so you shouldn't disturb that area when you are planning for lip reconstructions. So try to preserve the integrity of the modulus.
The next question is by Dr. Vinayak. Is 6 centimeter diameter the cutoff for any distant flap in the lower lip reconstruction?
Sorry, can you repeat the question?
Is 6 centimeter diameter of the defect is the cutoff for the distant flap reconstruction?
There is no such thing as, for distant flap reconstruction, the two main indications are total lower lip reconstruction, or if you have total lower lip reconstruction with adjacent skin loss. So you have to have at least 9 centimeters of lip stock intact if you want to borrow from the lip or from the cheek. So there is no size cutoff that is measured like that. It's only the total lip loss or total lip loss with chin skin loss. And you should have at least 9 centimeters and more of remaining lip to be able to borrow and have a intact intercommissural area of 3 centimeters.
Okay. So the next question is, does Doppler help in any way regarding blood supply of flap before division of the base flap?
And if you Doppler it, you'll be able to Doppler the pedicle where it's running, but then you have to know a way of having being sure that the flap is derived blood supply from the surrounding tissue. That can be only done by manually compressing the pedicle. Only if you manually compress the pedicle and impede the blood flow through the labial artery, will you be able to see if there is any collaterals that have developed from the surrounding skin. So you'll have to manually occlude the artery.
So the next question is by Dr. Sriram. Is there any cutoff measurement to select which specific flap to reconstruct in a lower lip defect?
Which cutoff?
Any specific measurement
Again,
to give a cutoff that this specific flap has to be?
It's only 1/3, 2/3, and more than
Okay.
2/3. It's only
Okay,
the
sir.
same thing. 1/3, 2/3, and more than 2/3.
Okay, sir. And there are two questions from Dr. Vinayak. Is that can we use proline for the facial injuries in case of a facial injuries? What's your opinion on using proline?
For the skin?
Yes, sir.
That is fine. That is so much. That's quite good. I mean, because proline or ethylone both are fine. You just have to use fine proline or fine ethylone and remove the sutures on the 5th day itself. The edges should be clean cuts. There should be no ragged edges. And you have to have good approximation of the subcutaneous tissue, either with PDS or vicryl, undyed vicryl, because the final scar on the outside doesn't depend upon the skin closure alone. It's the how good the subcutaneous tissue is closed, because the subcutaneous and the cuticular tissue is what provides structural strength to the scar, final scar. So it doesn't matter if you use nylon or ethylone. Ethylone is probably easier to see and remove, especially in places where there is hair. But you should have fine cut edges. You should have good subcuticular approximation or subcutaneous approximation and fine sutures for the skin. Avoid picking up the skin with forceps. Just use your thumb to gently evert the lid margin and remove the sutures on the 5th day. Avoid tightening the suture too much, otherwise there'll be railroading of the skin. You can see the railroading pattern on the skin if the suture is too tight. So try to avoid all that.
Okay. So the next question is, what is your opinion on nasolabial flap in using for the commissural defects?
So you can use the nasolabial flap, but the problem with the nasolabial flap is that that part of the commissure, you lose commissure competence there. So you have to be prepared for that. You can use a nasolabial flap, you can turn it over and see a superiorly based nasolabial flap. And you take the nasolabial flap all the way down. So the flap starts here and you go all the way down. You can turn the nasolabial flap and reconstruct the commissure and the buccal mucosa defects. But it still doesn't have any sphincteric action. That's the problem. So it can be done, but you're going to have a incompetent sphincter there.
Okay, sir. So the next question is
The
by
only way
Dr.
to reconstruct the sphincteric competence is by using a tendon or using a sling tissue which goes from the upper lip to the lower lip. Otherwise, you're going to have a incompetent commissure on that side.
Okay, sir. So the next question is from Dr. Rahul. What is the success of dynamic or sensate flap in reconstruction of the lip?
Sensate flap for the lip?
Yeah, dynamic flap. I think you're talking about the sling flap, no, sir.
Well, dynamic flaps are okay. If you use a palmaris, at least in the patients that I've done, see, the lower lip just has to behave like a vertical dam. The height has to be maintained and the upper lip can purse. The person can purse his lips and close the mouth. So you have to be able to have adequate lower lip height. If that is maintained by the sling, then the oral competence is quite okay. And all the patients that I have done, total lips, they're quite okay. They're able to use the lower lip as just a physical dam. It's just a vertical dam where the upper lip rests on. The good question that they asked, the other part of the question that they've asked is sensate flaps. Theoretically, you can do a sensate flap because you have the median and lateral antebrachial cutaneous nerves in the forearm, and they can be anastomosed to the branches of the mental nerve that are exiting the mental foramen. The mental nerve has three branches, to the lip, to the vestibule. So you have the branch that goes to the lip. You can identify that and you can still suture the medial or lateral antebrachial cutaneous nerves, which can be harvested as part of the radial forearm flap and anastomose. I've never done it. So in theory, it is possible to do a sensate flap reconstruction also. Because I think having a sensate lower lip is also important because temperature perception is important for patients also. But I think in due course of time, the sensory nerves do grow in from the surrounding tissues and the lip regains some sensation afterwards. But talking about the dynamic thing for lip reconstruction, the radial forearm with a palmaris or a facial aorta sling is the best way to do it.
Thank you, sir. Sir, the next question is very interesting. If microstoma in Karapanics cannot be prevented, should we consider free flap or should we go ahead and repair with the Karapanics and repair microstoma at a later date?
It's very difficult to repair microstoma at a later date because patient will go for radiation, patient will it's a functionally very crippling condition to have. It's not very easy. So uh, the problem with lip reconstruction is what you see on table, it will get worse. It's not going to get better. So you probably do a Webster Bernard by borrowing tissue from the cheek, or you just do a free flap, and because Karapanic just results in a unbearable microstoma at times. So I mean, people have done stretching and revision of the commissure and advancement of skin and buccal mucosa. All that is fine, but the moment you do that, you lose competence of the commissure. So you're going into another problem after that. So if the defect is too long, Karapanic is better to avoid. It's okay to do a free flap with a sling than do a Karapanic, I think.
Sir, again on the context of the reconstruction, Dr. Deepmala has a question that how many months do you wait after RT to take a patient for the secondary revision or reconstruction?
The delayed effects of radiation are there till 2 years after the radiation has been given. So radiation has, primary effects, secondary effects. The tertiary effects of radiation can last for up to 2 years. And you also have to see the dose of the radiation and what was the hotspot of the radiation. Because if you try to do something and if the wound breaks down, you're in a lot of trouble. Unless you import fresh tissue, you will not be able to reconstruct the defect. So wait for 2 years. The earliest is a year, 1 year. If you can, please wait for 2 years before you plan for the revision procedures.
Okay, sir. Another good question is that what is the best approach for reconstruction for recurrent diseases of lower lip? By Dr. Jimmy.
recurrent disease as in you've already done a flap reconstruction, or so
He hasn't
let
mentioned, but I think that
yeah,
maybe recurrences.
I think that if you have a recurrent disease, you again look at the defect and decide what you need to do. There's no specific. So if the patient has already exhausted his local flap options, he's had a primary reconstruction, primary tumor that was excised, and he's had an abbey, or he's had a slander, or he's had a gilly, and he's having further loss of lip substance. And if he can maintain the minimum 9 to 10 centimeters of lip stock, and if the labial artery is still intact, then you can think of doing an abbey or an slander. But if an abbey or slander has already been done, then it's quite difficult to use a local flap from the upper lip. Then you can think of doing an advancement from the cheek or advancement from the mentum. That is option number 2. But in most cases, a recurrent tumor margins are more ill-defined. The defects are slightly larger. The defects don't yield because of scarring and fibrosis. So would probably in the end up with a free flap, I think.
Okay, thank you, sir. Another question by Dr. Suresh is that in case of a lid reconstruction, what is the suture number you use? He's asking about 60 material.
Sorry,
In
which
case of a lid, Dr.
yeah,
Suresh.
60 is fine.
Okay,
If you have a spatulated needle, 60 is fine.
The next question is by Dr. Abhimanyu. In which plane to tunnel the sling in remnant upper and lower lip? And should the ends be secured externally?
No, you just have to secure it to the orbicularis. So you'll have to make stab incisions on both upper and lower lips. Then you'll have to dissect between the skin and the mucosa and the underlying muscle so that you don't damage the vascular pedicle on the deeper aspect. Then you tunnel under the skin and the mucosal surface, bring the sling and suture the sling with a figure of 8 onto the underlying muscle. So the sling is attached to the muscle rather than the skin. And then you close the skin with a vicryl suture or a prolene that you want to remove. But try to preserve don't disrupt the upper lip orbicularis continuity. Don't go deep to the upper lip orbicularis because you will damage the vascularity. Stay above it, but just bring the, the facial arter or the palmaris and then suture it to the muscle in a figure of 8. And it should be sutured quite tightly, so don't make it a lax suture.
Yes, sir. So again, the next question is by Dr. Deepmala. Would you consider MSAP with plantar sling as an alternative to radial flap, flap with PLC?
See, the MSAP is a perforator-based flap. It's not a septocutaneous flap, or it's not as vascular as a radial forearm flap. See, you can, I mean, you can basically use any thin flap. You can use MSAP, or if the patient is very thin, you can still use a ALT flap also with a facial arter sling, as long as the perforator is away from the sling. But my contention has always been that in a radial forearm flap, you still have parts of the pedicle that are attached to the skin, proximal and distal to the palmaris tendon. So even if there is compression of the dermal blood supply, because of the cutaneous attachments, I wouldn't say septicus. The word I would use is the radial forearm has got a very long segment where it gives feeder vessels into the to the skin. So if you make a small opening and tunnel the palmaris, you're still having intact connection between the vascular pedicle on the proximal aspect of the flap as well as the distal aspect of the flap. So even if the area of the sling is tight, the dermal circulation is not affected because you have blood supply from intact connections on both sides. So I'm not sure how it would work in MSAP. I've done ALT for a lip where the perforator was on the outside, the skin aspect, and it worked fine. But it is possible. I don't see any reason why you cannot do it. But again, MSAP, you have to, pedicle length is only 6 to 8 millimeters. You might not get enough. You have to see, MSAP is good to take if you're going to close the donor side primarily. So nothing more than 6 or 8 centimeters width you can take. So if you have to create a vertical dam of lower lip, you have to create a vertical height in the lower lip, you might need slightly more. So it is possible, but the more reliable alternative would be to use radial forearm or ALT.
Okay, sir. As of now, that's the end of all the questions are there, sir.
Okay.
And I thank you very much, sir, for giving this
Sure.
presentation. And I just wanted to mention to everyone that there is a next presentation in the coming Wednesday, which I will be putting up in the groups as well as on the Facebook. So with that, Marks, I would like to conclude it. Sir, you want to say anything?
Nothing. I mean, the lid and lip reconstruction. Um, it's a lot about local flaps. It's not about free flaps that we use. So it takes some time to learn planning and to learn the execution. So it's only drawing and understanding the incisions and understanding how to respect the incisions. And uh, this is probably the two areas where local flaps outweigh free flaps any day. So I hope that you find more interesting material to read and sort of get more interested in lid and lip reconstruction.
Sir. So we'll take leave, sir.
Yeah, thank you so
Thank you.
much. Thank you all
Thank you.
for attending, and I'll see you next week again. Thank you.